Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 72nd virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Surgical Options for Knee Pain, from Arthroscopy to Knee Replacement, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. The knee is the largest joint in the body, connecting the thigh bone to the shin bone and the kneecap. It is primarily a hinge joint, meaning that it allows for flexion, bending, and extension, straightening of our knees. In addition, it also allows for slight rotational movement, especially when bent. We rely on our knees to transition from sitting to standing, to walk, to jog, and to run, to play nearly every sport, and to do most activities of daily living. However, approximately 25% of adults in the US experience knee pain, accounting for nearly 4 million primary care visits annually. Knee pain affects people of all ages and activity levels. It may develop from an injury, arthritis, or wear and tear over time, and can make everyday movements like climbing stairs, walking, or simply standing difficult. Tonight, Illinois Bone and Joint Institute's Bruce Summerville, MD, will discuss the latest surgical options available to treat knee pain, from minimally invasive arthroscopy to partial and total knee replacement. Dr. Summerville is a board-certified orthopedic surgeon with fellowship training in adult reconstruction of the hip and knee. He practices in the Gurnee and Lindenhurst IBJI locations. Dr. Summerville's areas of expertise include arthritis, arthroscopy, primary and revision shoulder, hip, and knee replacement, anterior hip replacement, partial knee replacement, ACL surgery, meniscus surgery, rotator cuff surgery, bicep and labral cartilage surgery, trauma, fractures, and the evaluation of disability and impairment ratings. Dr. Summerville attended medical school at Rush Medical College and did his internship in general surgery at Northwestern University, where he also completed his residency in orthopedic surgery. He completed his fellowship training in orthopedic adult reconstruction of the hip and knee at Thomas Jefferson University. Dr. Summerville's goal is to treat individuals without surgery if possible, but in cases where surgery is needed, he provides his expertise and technical skills to make sure that his patients achieve the best possible outcome. He believes in taking the time to thoroughly explain the condition, affecting, and the treatment options available to each of his patients so that they can participate in decisions about their care. Whether a patient comes in with a complex condition requiring significant knowledge and expertise, or one that is less serious, Dr. Summerville believes in providing the same level of compassion and attention to all. His passion extends beyond orthopedics to each and every one of his patients. And in addition to working with patients, Dr. Summerville is a fellow of the American Academy of Orthopedic Surgeons, a member of the American Association of Hip and Knee Surgeons, as well as the American Board of Orthopedic Surgeons, a member of both the Illinois and the Lake County Medical Societies, and is on the Diplomat National Board of Medical Examiners. During Dr. Summerville's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the questions section on your screen, and I will receive them and relay them to Dr. Summerville immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Summerville via one of the options that will be listed on the slide shown during the Q&A portion of the program at the end of his presentation. One more thing before I turn the evening over to Dr. Summerville. Please mark your calendar for our next IBJI and NSYMCA Education Series program, entitled Understanding Common Adult Shoulder and Elbow Issues, which will be hosted by Dr. Ryan Harold on Tuesday, March 31st at 7 p.m. Thank you again for joining us tonight, and thank you, Dr. Bruce Summerville, for your time and effort in putting together this program explaining surgical options for knee pain. Dr. Summerville, please take it from here.
Okay, welcome. Can everyone see my screen here?
Looks great,
Okay.
thank you.
All right, thank you for that kind introduction, Karen. And we're going to cover a lot of material, so everyone buckle up. I can't obviously speak in great detail about every aspect of care of the knee because it is a complex joint and there's many aspects to it that require different treatment and care, but I'll try to cover as much as I can. As Karen already told you, I've done most of my training in the Chicagoland area. I spent 1 year in Philadelphia at the Rothman Institute, where I completed training in hip and knee replacement and revision hip and knee replacement. You can see otherwise, though, I've been at Northwestern and Rush Medical College in Chicago. All IBJI physicians are board certified, which means that there's a governing board that reviews our cases. We have to take tests, and it's a 10-year cycle. We also have peer review from our colleagues to confirm that we are acting appropriately and performing, appropriate and indicated surgeries. So switching now to knee pain itself, I'm well aware when I see my own patients how debilitating this can be, whether one has arthritis or simply just kneecap pain, tendonitis, things that are more simple that may not need surgery. And I think Karen said it the best. It involves every aspect of our lives, getting up and down out of, from a chair, climbing stairs, playing sports. So I'm very aware and obviously appreciative of how much this can affect individuals' day-to-day life. Now, this is a very busy slide. This is the anatomy of the knee, and the reason I included this is just so you could get a sense of how complex the knee joint is. It was said earlier about bending and straightening, and honestly, there's even more complexities to the knee. The knee actually pivots and rotates and glides and slides forward and backwards, even with the ligaments working appropriately and intact. And so you can see that there's many aspects to the knee that unfortunately, because of its complexity, could result in painful situations or even injury. Here's another knee anatomy. This talks more about the terminology we use, and I'll get into that in a moment when we physicians talk about, as you probably all know, we have our own language: anterior, posterior, that's front, back; medial's the inner side, lateral's the outer side. And that's how we communicate to each other. So we're all speaking the same language. And then if you look specifically at the causes of knee pain, these aren't all surgical causes, but something like patellofemoral pain syndrome is very common, and one does not need to have an arthritic knee to create a situation where they're applying a lot of stress to their kneecap and causing themselves pain with stairs and those kinds of daily activities. Patellar tendonitis is sort of in that same bucket. We call that the extensor mechanism. Your quadricep, your patella, your patellar tendon, any one of those could become irritated through increased activities. Sometimes it's through lack of sufficient, flexibility. And then you go to the next row, you see bursitis. There's these little potential sacs of fluid around the knee, which can become inflamed again from too much activity. Iliotibial band syndrome is a long tendon on the side of the knee, which can become irritated. And then cruciate ligament and torn menisci, as you can see here, tend to be obviously more likely to be surgical options. And then I won't speak that much about dislocations and fractures, because those obviously need surgery in most cases, although in some cases, if the broken bone is not out of place, it can heal without surgery and just a cast or a splint or something. Last slide on knee pain. This is a little bit redundant, but it's talking about much of the same issues that I just mentioned on the last slide. So when I see patients, or any orthopedic surgeon sees patients, they know their knee doesn't feel right or hurts, and they use these terms typically, in my experience. pain, achiness, fullness gives way. The pain is above or behind my kneecap, and that's why we as physicians use those universal terms, which I'll show you in a moment, so that we can all talk the same language to one another and understand each other. You know, behind or on the side of my knee, if it feels swollen or locks up, my whole knee hurts, the pain moves up and down my leg, it hurts when I sit or do stairs or twist. So in general, when we see patients, or I see patients, and they have one of those diagnoses that do not require surgery, we have excellent physical therapists, physical medicine and rehab physicians, and pain management physicians who can either treat entirely non-surgical conditions or can assist in treating patients either before or after surgery. So these are the terms that we often use. Medial is the inner side of one's knee, lateral is the outside, posterior is what most people would call the backside, anterior is the front, supra means above the kneecap, infra means below, retro means behind the kneecap. When we talk about pain, we're talking about what you feel. Tenderness is what I, unfortunately, when I examine patients, sometimes create, because we have to know where things hurt you. And effusion is fluid in the knee. That's very important to determine that, because most significant injuries from problems, or what we call pathology within the knee, are associated with an effusion. It's unlikely that one has a significant or potential surgical problem with their knee without an effusion, because the knee is relatively watertight. Edema is swelling around or outside the knee, and it can also be one of those cysts that I had mentioned can cause that sort of swelling outside the joint. Referred pain means it comes from somewhere else. I've seen patients who think that their knee is the primary problem, and actually they have hip arthritis that refers to their knee. They actually do not have any hip pain. Radiating pain means the pain in your knee goes somewhere else, down your leg, to your foot. Then there's localized, specifically, a patient can take one finger and point to an area. Diffuse means it's obviously more around the entire knee. Mechanical symptoms are symptoms of locking, giving way, giving out, something we do see with meniscal tears, which I'm going to get into soon. And varus and valgus. Varus means that's a bow-legged alignment of the leg. Valgus is knock-kneed. So again, the translation, it's my job to translate your symptoms and what you're feeling into what may be the cause of your symptoms. So front is anterior, back, posterior, the side, and then the other terms that I just mentioned. Again, non-surgical conditions, often patellofemoral kneecap pain, tendinitis of your hamstrings, patellar tendon, quadriceps, bursitis, or those little sacs of fluid that can blow up if they become irritated, and some ligament tears like the medial collateral ligament on the inner side of your knee, if stretched, don't need surgery typically. Again, not all knee complaints are the same, but common conditions happen commonly. The same condition may create different symptoms for different people. We all think and feel about things differently. Some people, can tolerate a higher level of pain or symptoms. Others are more aware of it. And so we have to take all of that into account. Most patients don't show up in my office and say, I think I have a meniscal tear, although some do. Some know they have knee pain, although they don't know yet that they have arthritis. But the conditions we see most commonly are arthritis and meniscal tears. So when we talk about causes of knee pain, we're talking about intrinsic, things within the knee or around the knee, meniscal tears, arthritis, infection, trauma, tendinitis. Extrinsic causes are outside the knee. Hip arthritis, as I just mentioned, can actually radiate towards the knee. Pinched nerves of the spine can cause pain down the leg to the knee, and some individuals will experience just knee pain, and yet their symptoms are the result of a pinched nerve in their spine. So this is medical school 101. And what I mean by that is when any of us see a new patient, it's chief complaint, and that would be knee pain, and then the history. What are your symptoms? When did they begin? Has this happened before? Have you had any surgery on the same knee or same leg? Are there any other symptoms such as fevers, chills, numbness, tingling, which is what I was alluding to with the pinched nerve? Fevers, chills could indicate an infection. Does the pain radiate or refer to somewhere else in your body? So then we perform an examination. And again, as I said earlier, tenderness is what I'm doing to your knee. Unfortunately, sometimes we have to elicit tenderness to determine where the source of the pain may be. And a fusion is very important for me to help determine whether there's an actual problem within the knee joint itself. And then instability would be a matter of testing the ligaments and testing the knee to see if it falls within the amount of stability that we would expect in most people's knees. If not, it could suggest some sort of ligament tear or even a meniscal tear. And then there's something called provocative tests, meaning that if I twist your knee, that could be a good positive finding suggesting a meniscal tear. Lockman's test is the classic test where one's knee is held at 30 degrees bending, and we try to pull the tibia forward on the femur to see if the ACL, the anterior cruciate ligament, is loose. Again, a knee effusion in my world, when I see patients, is very important to help me determine, is there potentially something within the knee that's causing it to swell? Because by and large, most pathology, most injuries are going to make one's knee swell. Then after an examination, by and large, most orthopedic surgeons, including myself, are going to order x-rays. Can't be stated how valuable x-rays are. It's not uncommon that patients will come to my office unaware that they have bone-on-bone arthritis or that they have significant arthritis already. My typical algorithm is if your x-rays are normal and I'm suspicious of something within the knee itself, often a meniscal tear or something else, I'll order an MRI scan. As you probably all know, an MRI scan is just a large magnet, and it can show different shades of gray and white, which from our experience, we know the normal knee has a certain appearance on an MRI, and we've determined over time what abnormal pathology or problems in the knee will look a certain way, and then help determine if one has a meniscal tear or an ACL tear. Weight-bearing x-rays are also very important because particularly arthritis can look relatively normal when laying down, but with weight-bearing x-rays, because that's when most people are painful, we can see that the joint between the tibia and the femur is narrowed, and that is sort of the indirect way that we evaluate x-rays to see that the joint space, as we call it, is either preserved or narrowed. MRI quality speaks to the strength of the magnet. The magnet in Gurney is the highest strength available currently, 3 Tesla. Not named for the car, but named for the turn of the century scientist. Now let's talk a little bit more specifically about things that are seen quite often. So meniscal tears are extremely common. There's different types of tears. They can occur medially or laterally. They can be a bucket handle tear, which means that it's still attached in the front and the back, and this piece can flip back and forth. Those are quite uncomfortable and painful because when that piece is flipped in the wrong position, a patient is actually walking on that piece, and the nerve endings that connect to the side of the meniscus are stimulated and cause pain. These are other types of meniscal tears, flap tears, radial tears, and this is more of a degenerative tear pattern. And the shape of the tear and the size of the tear help dictate what procedure we recommend for surgery. And we can get into that in a little bit, but bucket handle meniscal tears, we are going to be much more likely to want to repair and try to repair, because if all of this tissue has to be removed, the meniscus, which is a shock absorber for the knee, is now diminished in its shock absorbing ability and can lead to relatively early term arthritis without that piece of meniscus. So we do try to repair those and get those to heal. In general, meniscal tears are quite common. Under the age of 40, they're typically caused by trauma, whether it be sports or just twisting the knee aggressively in the wrong way, performing some activity. Whereas over 40, they can occur due to trauma or just from normal daily activities. I'll see patients who try to associate their tear with some incident. They might remember gardening, bending down, squatting, and then realize the next day their knee feels swollen or painful. The typical symptoms are pain, swelling, and sometimes locking. They can also be seen with arthritis in individuals over the age of 50. We have to remember that arthritis is not just loss of the joint cartilage, but it's degradation and degeneration of the entire knee itself. So the meniscus can tear over time as a result of the arthritis. Even the ACL can stretch out over time without any injury. The common complaints that I hear are, quote, my knee just doesn't feel right. Most people with meniscal tears, unless it's a bucket handle tear, they can continue to go on with their life. They can go to work, they can function, but they just know something's not right. It feels different, or they can't straighten all the way. So this is sort of the classic exam test that we all perform if we're suspicious of a meniscal tear. We bend the knee backwards all the way, twist the ankle in or out, and try to catch that meniscus fragment underneath the femur and tibia, and then straighten the knee. And the classic way it's been described is it causes pain with a clicking sensation. But most of us will consider it positive if it just causes pain. Now, as far as MRIs go, a good quality MRI scan, as you can see on the normal side here on the left, the MRI looks like a little wedge back, the meniscus looks like a little wedge. Here you see that little white line in the wedge or within the wedge. That's consistent with a meniscal tear. However, studies have shown that many tears are present in asymptomatic people, because we've done studies where we paid volunteers to have their knees MRI'd, and they don't have any symptoms, and yet they have an abnormal finding on MRI. I know that could be a hard thing for people to wrap their head around, but it is possible to have an abnormal MRI and yet have no symptoms. So we can't just treat a patient based on their MRI findings. We have to correlate with their symptoms, their exam, et cetera, et cetera. So the classic treatment of a meniscal tear, as many of you may know, is something called knee arthroscopy. It's a minimally invasive procedure. We make little stab wounds, and as you can see on the right, we're able to put a camera in. We're running fluid through the knee, and then with the other hand, as we hold the camera, we use a scissor, or we have in that picture what's called a probe. A probe is just a blunt hooked device that allows us to examine tissue by pulling on it and seeing if something is loose or unstable. I would say, and I think data confirms this is the most common procedure for any orthopedic surgeon worldwide. The good news is when a meniscectomy is performed, the procedure is associated with a rapid recovery. There's no real restrictions afterwards. Most patients, if they have a symptomatic meniscal tear, will feel pain relief from that condition within the first week or even days after the procedure. Obviously, the surgery itself is associated with some development of swelling that needs to subside over time. Then the question is, okay, so when do we perform a meniscectomy and when do we repair? Generally, under 40, we're going to attempt to repair, and the reason is the healing potential and the blood flow to the meniscus is satisfactory enough that if we put sutures in there, it's likely to heal. Bucket handle tears, as I said before, we try to repair because removing them is a pretty significant, potentially devastating effect on the knee in the future of one's knee, as decades later, one may develop arthritis because of removal of that cushion tissue of the meniscus. Meniscal root tears, I'm going to get into in a little bit more detail. That's something we've recognized more recently in the last decade as how important those are to be repaired. As far as trimming it, as we say, meniscectomy, generally for people over 50, unless they have a bucket handle tear or meniscal root tear, if it's a complex tear, degenerative tear, we would generally just trim it, because complex means it's more than one clean tear. It's multiple tears that you can't adequately get suture in. White zone tears mean they're in the periphery. Those don't have much blood flow and those don't heal well. Radial tears, based on the way they're shaped, are hard to repair. But again, in younger people, we have certain instruments to try to repair those. So again, you see on the left, there's a trimming of the meniscus. On the right, you see the sutures, and various manufacturers and companies make instruments to be able to allow us to sew a meniscus together. In the past, we would make an open incision when I was in training, and we would actually visually see the meniscus and put sutures in it. Now it's, by and large, it's done with what we call the all-inside technique, where we just have the scope and the repair device. So you see the thirds. The meniscus is broken into thirds. 3 would be the area that's avascular. We tend not to repair those. 1 and 0 is where we would tend to find the best results for repair. These are the meniscal roots posteriorly in the back, if you remember the nomenclature. These we tend to be more aggressive in trying to repair. Here's an arthroscopic photo of a tear of the posterior root. This is just some pictures intraoperatively, how the sutures are placed. This is a schematic of how we pass sutures. There's 2 different ways to do it, to repair the tissue, and this is sort of an algorithm of who's a candidate, who's not a candidate. But again, none of these are completely absolute, except, somebody already has arthritis, or they already have a bow-legged alignment of their knee, because we're trying to prevent arthritis. If somebody's already showing signs of early arthritis, it's probably not a good idea. It's not going to make a difference if we repair the root. So anterior cruciate ligament tear is another, probably the most widely studied injury of the knee in the orthopedic literature. Again, as we all know, this typically occurs in younger patients, athletes, usually due to trauma. By and large, non-operative treatment is indicated for those over 50. But there are exceptions to the rules. I've certainly done some ACL reconstructions in very healthy, active early 50-year-olds. The main issue with this is not so much that it causes pain, but it causes instability. Patients are fearful their knee will give out. And so by and large, for younger patients, 50 and under, 40 and under for certainly, we're going to recommend ACL reconstruction or repair. And the reason is, number one, if the knee's unstable, it can lead to early arthritis. So arthritis when one is 50, not 70, or it can create other injuries of the knee like meniscal tears, because the buckling of the knee can harm the other parts of the knee. So most commonly, ACL tears are acute, associated with significant trauma and sports related. Other injuries that can occur simultaneously are meniscal tears or osteochondral fractures, where a piece of the joint cartilage is chipped off the bone. Chronic tears that are left untreated can lead to meniscal tears. And even, unfortunately, ACLs that are reconstructed and stabilized can still, unfortunately, lead to arthritis decades later, even though that risk is lowered by doing the surgery. The various graft options are allograft, which is a cadaver graft, autograft. By and large, we use autografts in younger people. They have allografts have a higher rate of failure in younger people, say under 20, 30. We treat the associated injuries. Classically, we perform a reconstruction, which means we have a graft substitute for the tear or for the ligament. But what has become more popular recently, particularly with very young, like teenagers, is a repair of the ligament. And so that is an option. You can see this schematic here. Classically, for the graft choice, we use the hamstring tendons around the back, the patellar tendon, and now sort of more popular is the quadricep tendon, just taking the middle third. And basically you remove the tissue and we reconstruct a graft of their right or appropriate length and diameter, and then reinsert that through these drill holes into the joint and fix it with screws or buttons or suture or whatever one wishes to do. Just a brief discussion about infection. Individuals do develop acute infections with, redness, warmth, loss of motion, pain, fevers, and these are somewhat surgical emergencies. And the reason is not only can an infected knee lead to significant sickness for the patient, but it can lead to damage to the joint cartilage. So we tend to be aggressive with treating infections. Gout does not require surgery, but it sometimes can be confused with infection. And so often we'll draw fluid out of the knee and we can differentiate between infection and gout in that way. I mentioned this earlier, osteochondral defects or fractures. These can be due to trauma, or they can be found incidentally when doing a knee scope for a meniscal tear. And so there's, by and large, two ways to repair these. We take parts of bone and cartilage from the knee where we know it's extra-articular, where, in other words, it can be sacrificed, and then we can use those little plugs to fill the void that we found at the time of surgery. MACI is a two-stage procedure where we harvest cartilage, grow it in the lab from that individual, and then return weeks later to fill that gap for the osteochondral fracture, or something else that's called osteochondritis dissecans, which is where the bone has died for unknown reasons. We think it's a blood flow issue, and it typically occurs in younger individuals in their 20s and teen years. We can perform the same procedures for them. Osteonecrosis is typically a wider spread area of an osteochondral defect or osteochondritis. It's essentially death of a localized area of bone, typically the medial side of the femoral condyle, the inner side. It causes constant pain, even at rest. It's most commonly what we call idiopathic, where we don't really know what the cause is. Individuals haven't sustained trauma. They have no other risk factors such as excessive steroid use, or not excessive, but steroid use or excessive alcohol intake. And so, unfortunately, they develop this spontaneously. And because the problem is within the bone itself, injections and medications don't really effectively treat it. Once collapse of the cartilage has occurred, it typically won't heal. So the underlying bone is like the soil, the grass over the bone is like the cartilage. Without the underlying bone being healthy, the cartilage is going to collapse, and sometimes these cartilage fragments float away and there's a hole there, there's a defect there. And so surgery using a graft material may be successful depending on the size of the area, but often individuals will need a partial or full knee replacement depending on their age to effectively treat this. Here's just a schematic about staging of osteonecrosis. Again, higher stages typically require an arthroplasty because the bone has collapsed, or the cartilage has collapsed, and once that's occurred, unfortunately, there's no going back. And many of these people who are older anyway, if they're 60 and above, it's a more predictable outcome to do an arthroplasty procedure rather than try to place a bone graft or a donor cadaver graft and hope that it heals. So we often will do an arthroplasty procedure. All right, so knee arthritis, extremely common. I think in the United States, there's almost 1 million knee replacements done annually. I would say it's second only as frequent to arthritis at the base of our thumbs. It's most commonly caused by obesity, but there are genetic causes in thin individuals. Post-traumatic arthritis can cause after, as a result of a fracture, a meniscectomy, or as I said earlier, even an ACL tear that wasn't treated or was treated, but in spite of that, one can still develop arthritis. As many of you know, if just the advertisements for treatment of this consists of non-steroidals like Aleve, Advil, cortisone injections, visco supplementation injections, which I think most people would refer to as gel injections, bracing, radio frequency ablation, RFA, which is actually burning of the nerves that create the nerves, or the pain sensation, take that sensation away from the knee to your brain. So they burn the nerves where they exit the knee, and that can provide relief for up to 6 months. And then ultimately, the final step would be a knee arthroplasty. So as you can see, we throw this term osteoarthritis, arthritis around. Osteoarthritis is really just the wear and tear. As I said, either due to obesity or some other cause. There are other causes of arthritis. Rheumatoid arthritis is an inflammatory cause, and that's less common. Most of what we see is osteoarthritis. You can see on the right, there's areas of lost cartilage where it's wearing away. There's narrowing of the joint space, as I mentioned earlier on x-rays. You can see this picture. So again, we like to get x-rays of a knee with one standing and see if the joint space is narrowed or not. It can occur in any one of these compartments isolated. There's 3 compartments to the knee, as we call it: lateral, medial, patellofemoral. And any one or any number of those compartments combined can be involved with osteoarthritis. Symptoms, again, typically involve swelling, locking, pain. And when one has arthritis primarily on the inner or medial side of the knee, they begin to look bow-legged, or what we call varus. When it's on the outside of the knee, which is less common, probably only 10 to 20% of patients have a valgus deformity. That means their arthritis is on the outer or lateral side of the knee, and it begins to deform their leg. Patellofemoral arthritis is, in my opinion, more common than people would think. And unfortunately for the ladies in the audience, it's 8-to-1 female ratio over men. Not sure exactly why that is, but if one is a candidate, we can perform an isolated patellofemoral joint replacement and avoid treating the other parts of the knee if they're in good health. It's a fast recovery, and on average, it's indicated for individuals under the age of 60 years of age. 60. The reason being is that the concern is that if you just do the patellofemoral joint as a surgeon and somebody's over 60 and the rest of their knee then becomes arthritic, now you have to do a second operation. But if somebody's only 45, you're really not going to want to do a full knee replacement on someone that young. And if you have the option to do a patellofemoral replacement, if the rest of the knee is healthy, that would buy that person time, potentially 15 to 20 years. And then when that device fails or loosens or whatever the mode of failure is, because all of these devices potentially are going to fail over time, the cement loosens or whatnot, then you could convert that person to a full knee replacement. So I actually do a reasonably large number of these, given that they're not that common, but they are effective. I would say these are some of my happiest patients because they've had an operation that's somewhat minimally invasive. They have a smaller scar than their total knee friends and families, and the relief that they experience is so rapid and they recover so rapidly. So if you have that bone-on-bone patella here, and just constantly all day long with sitting, stairs, getting in and out of a car, you're just miserable. And then we put this surface here, and on the other side is the kneecap as a plastic dome that will run over the top of this metal piece. You no longer have any pain. It's very life-changing. One other partial knee replacement that I'm very passionate about, or partial about, no pun intended, is a medial or lateral, but more commonly medial on the inner side of the knee. If someone has a varus deformity and they're bow-legged and their arthritis is just on the inner side of the knee, we can do a partial knee replacement. Again, because we're not opening up the whole knee and we are doing quote unquote less surgery, there's less swelling, there's less pain, and the recovery is faster. The knee replacement that I use is proprietary, meaning that only one manufacturer makes it. It's called the Oxford Mobile Bearing Knee, and it's a very revolutionary design compared to the fixed bearing. The plastic within the device, you can see the little line and the dots there, will actually move with the knee. The point of that is knee replacements and partial knee replacements go bad at 15, 20 years because the plastic either wears out or the cement connection between the metal and the bone loosens, just like grout in your bathroom, you know, it has to be redone. This little plastic bearing, because it moves with the knee, it's not fixed, will not wear out. The friction on that is 1/100th of a fixed bearing partial knee replacement. Now, this year, or 2025, last year, the FDA now has approved the cementless application as opposed to cemented for the tibia and femoral components. You can see they have this little gritty surface here. So once those go in and the bone grows into them, just like a cementless total hip, that becomes a permanent prosthesis. So if that's permanent and the bearing's not going to wear out, the only way that this is going to fail is if, God forbid, somebody develops an infection, because any arthroplasty, unfortunately, even years later, could potentially develop an infection down the line. Or if somebody were to fall and fracture the bone around this. But just through normal wear and tear, this device should not fail. And at this point in time, we're considering this potentially a lifelong prosthesis. Data has shown with this that, because people ask, well, what about the rest of the knee? What's going to happen there? And in large studies, maybe 3% of people will have the other parts of the knee become arthritic. So in my opinion, to get this little prosthesis that could last a lifetime, to take that 3% risk is worth it. So knee replacements, I don't need to talk a lot about those. Every manufacturer has their own slightly different design. The designs have changed, but the basic concept has remained the same from when they were first developed in the early 70s. What has changed, though, is the technique. Now we're using robots and those sorts of things, and also the pre and post-surgical care have evolved. So has part of that is the pain management has evolved. So we no longer have patients go to skilled nursing facilities for 2 weeks. Many, if not most, patients have this operation and they go home the same day. So I'd be happy to answer any more questions about that, but I think most people are familiar or have had friends or family that have had a knee replacement and have an understanding of what's involved there. So thank you for your attention. That's the end of my presentation.
All right, are you ready for questions?
I am.
Okay, let's go back. There's a few that came in regarding menisci, so I thought I'd start with those because that was the first area that you focused on.
Sure.
And I thought this was kind of an interesting question. So someone says, so a meniscus tear that produces no pain isn't a problem?
Well, number one, that's uncommon. So the issue is, how old are you, right? So if you're 20 and you have a meniscus tear, I'm going to want to try to repair that, even if you feel like, oh, well, I can live with it. The concern is it's going to become larger and may become painful, and or, as I said, no longer be repairable as it shreds further and becomes larger, whereby you, we can't get those sutures in now. We can't get it to heal. If somebody's 50 or 60, there's a term in medicine called benign neglect. If they're like, yeah, well, I have occasional discomfort here and there, but I can live with it, there's no downside to not operating on that person. So it is age dependent. The size of the tear kind of has an impact on this. But, large tears, I don't think somebody with a bucket handle tear, although I shouldn't say that, I have seen people who amazingly can tolerate a bucket handle tear, the big piece that flips across. So
Right.
it is age and tear dependent, I would argue.
Okay, very good. And I think they were probably referring to the studies that were done where, they did the MRIs and found these people who had meniscal tears. I think that's kind of what they were referring to, but I think that's a really good answer. So thank you.
It's a great question. And, in general, it's very hard to talk people into surgery if they're not particularly symptomatic.
Yeah.
In our world of orthopedics, obviously, if somebody is told you have cancer, they're going to submit to whatever treatment or surgery.
Right. That makes sense. Okay, another meniscus question. Is there anything that can rejuvenate the meniscus between your joints?
You mean once it's been removed, or instead of performing surgery? So there's, okay, so if somebody has their meniscus, a large part of it, sort of the 50-yard line, 50% or more, there's concern about development of arthritis at a later date. So if you have that done when you're young, there's talk about PRP and other injections. I don't think the data is there yet and insurers don't cover that, so that's kind of a hard sell. In terms of rejuvenating it when you're older, I'm not aware of anything that's being done. The only other thing I would say is if you're young and your meniscus is removed, a large part of it, some patients are candidates for what we call meniscal allografts, where we'll actually take a cadaver meniscus and implant it into someone's knee to serve as the meniscus that was removed or damaged.
Got it. That makes a lot of sense. And yeah, you just answered a bunch of people's questions about what your thoughts are on PRP. Do you want to go into that any further, or
we offer it? Yeah, sure. We offer it. Insurers do not cover it. It's I don't know, $1,000. We can do it in the office. We take a blood sample, spin it down. It has been shown to be effective in other body parts like tennis elbow. I'm not aware yet of any great studies for the knee, but people do try it. It's not harmful. But again, it's age dependent. So if you're 60 or 65, I wouldn't waste my time or money. I would just, if I have an arthritic condition, I would just do the other traditional treatments, even an arthroplasty, and those are much more predictable outcomes.
Great, thank you, appreciate it. Okay, someone asks, so if I have a knee replacement, will my arthritis go away?
So what we do at the surgery is we take out the arthritis. So literally we take a saw, and if we're doing a full knee replacement, we resurface or remodel the ends of the bone. So now we have a raw surface of bone that we cement, or now even there are cementless total knees that are becoming more popular. We place those on the bone, so we're essentially covering the surface of the bone with the arthritis removed. And because we've covered the bone, there's no longer any area for the pain, for one to feel pain. We're covering the ends of the bone that may feel the pain.
And you've cut away the arthritis, so that arthritis just won't be there anymore to cause the pain.
In all parts of the knee. If it's a partial knee, we just do the arthritic side of the kneecap, or we just do the arthritic side of the tibia and femur, depending on what side that is.
Great, awesome. Yeah, it's one of those things that when you live in that world, it makes sense to you. But if you're new to all this, it's a good question. All right.
Absolutely.
We're going to go back a little bit. What causes the fluid buildup in the knee like a Baker's cyst?
It's a good question. Okay, so in children, they can develop Baker's cysts for no reason at all. Their knee is perfectly normal. But in adults, typically the fluid builds up within the knee, like I said, and effusion, something's causing the lining. The fluid is made by the lining of the knee. That's called the synovium. There's cells within the synovium that create the fluid. And they react, it's the body's reaction to something that's causing pain in the knee. And so that's the body's way of trying to cushion or buffer the knee. When that fluid becomes so large, the volume of it, the quote unquote hydrostatic pressure, the fluid pressure, pushes out the fluid in a weak spot in the back of the knee. So there's two muscles in the back of the knee that are like the shingles on a roof. They don't actually seal the knee, they overlap one another. And as long as there's not enough pressure on them, no fluid will escape. But once there is, the fluid will leak out slowly, and the body is very effective at walling off things like that. The human body does not like what we call dead space, where there's just air, there's fluid. So it'll make what's called a pseudocyst. It'll actually encapsulate that fluid, and so now you have a perfect storm. You have a capsular lining around the fluid. You have more fluid being created, and that cyst can get larger and larger. But then eventually something's got to give. Those cysts will rupture, cause swelling acutely in one's leg, and many of those individuals will go to the hospital thinking they have a blood clot because their whole leg is swollen acutely. But it's just a anatomic, I don't want to call it a defect, but it's just an anatomic fact that there is a weak spot in the back of the knee where the fluid can leak out.
Got it. That makes a lot of sense. Thank you. That's a great explanation. Okay, we're going to kind of move around a little bit now to knee replacements again. Is it possible to have a double knee replacement surgery?
Yes.
Do they still do that?
Data shows now that we tend to stay away from that for individuals over the age of 70. There's clearly higher risk, cardiovascular, stroke, heart attacks, that kind of thing. Now, that's not a hard stop. If there's a 75 or such year old that's in excellent health, then you could consider it. But generally, if we're going to do that, we would keep it. The indications are for somebody to be under the age of 70.
Great, thank you. Okay, you know what? That person left, so we're gonna address people's questions who are still on the call with us. All right. With already having arthritis and a meniscus tear, how do you know whether to do arthroscopy versus a full knee replacement surgery?
Yeah, that's a great question, because that's a dilemma that we all face every day, every week. I have my own algorithm, if you will, depending on how severe the arthritis looks on an x-ray, those standing x-rays with the joint space, whether it's narrowed or not. And then we get an MRI if they have a meniscal tear. So if they just have pain, you don't know whether their symptoms are due to the arthritis or they're due to the meniscal tear or both. If one has mechanical symptoms, locking, where the knee doesn't straighten all the way, that could be more likely to be due to the meniscal tear. So the way I work through this typically is I'll offer some sort of injection, whether it's cortisone or gel. And if somebody doesn't respond to that after a couple weeks, it makes me think maybe the meniscal tear is a greater part of the issue here. And so it's not a downside to do a scope, an arthroscopy, trim that meniscus. And if the patient unfortunately doesn't improve, then now you're faced with, okay, I think your main problem is arthritis. Whereas to perform an arthroplasty, obviously there's no going back from that. Right. So if somebody if they're not bone on bone, they have a reasonable amount of joint space left, and they have a meniscal tear. And plus, this is where the history plays into it too. Have you had pain for a year and it just got worse? Or were you doing fine and 2 weeks ago you twisted or something and now you tore your meniscus? We kind of recreate the history, or we backtrack and go, well, I think that's when you tore your meniscus. So it's a lot that kind of goes into it, but I'm trying to be more conservative first and not burn any bridges. you know, an arthroplasty is always the last resort.
Got it. Great. Thank you. That's a wonderful answer to that question. Okay. I'm just looking at this real quickly. Does an MRI give you the complete picture, or do you sometimes find other issues during surgery? If so, are you able to repair it if repairable? You kind of mentioned that a little bit earlier.
That's a great question. No, they don't. In fact, particularly with meniscal tears, they probably miss maybe 10 to 15% of tears. So that's why it's incumbent on us as a surgeon to explore the whole knee, which we typically do. We start in the knee patellofemoral compartment, then work our way around to the inner medial side and then the lateral side. But as long as you look at everything, we also typically, when one's asleep waiting to have their surgery in the operating room, we'll do an exam under anesthesia. Do they have full range of motion? Because sometimes in the office, due to pain, patients can't move their knee fully straight or fully bent, but under anesthesia, they can, which indicates that the only thing holding them back was pain and not actually something in the knee blocking its motion. But no, the MRI, even a 3T magnet, can miss things. So the good news is the locations where I operate, they have meniscal repair sets. They have these things on the shelf if you need them. So you don't have to come back.
That's great. You don't have to go back in again. Super. Okay. Can an arthroscopy be done under local anesthesia?
That's a question that I'm asked all the time. And I think that most people would tolerate the actual trimming and that aspect of it. But what people don't understand is, in order for a surgeon to see and move the camera around your knee, we have to put stress on your leg. And so what we do is we either lock your thigh in a thigh holder, or on the side of the table, we put a post made of foam. So I have my hip on the inside of your foot and leg, and I'm pushing your leg over against that post to open up the inner side of the knee. And then similarly, when we want to look on the outside, we bend your knee up and put it in what we call the figure 4 position and push down on the knee. So I think that would be uncomfortable. People wouldn't tolerate it, which means I'm not going to be able to complete the operation, because you're going to be, like anyone would, you're going to be fighting me against doing that.
Yeah.
So we do a very light general anesthetic. Patients tolerate it well. They wake up within minutes after the procedure.
Great. And you talked about all the other changes that have happened. The replacement itself is the same, but all of the things around the knee replacement really have changed so much. Pain management, all of it. So yeah. Speaking of which, someone's asking you to talk a bit about recovery from total knee replacement. Can you just address that a little bit?
Sure. So as I said, many, if not most of these, are done on an outpatient basis. Our excellent anesthesia team does a nerve block into the thigh. You also have a spinal anesthetic, just, like millions of women having babies get a spinal anesthetic. Your legs go numb so that when you wake up from the operation, you don't feel the pain, but you have function. You have control over your muscles. We then have patients go home. Usually it's an opioid or narcotic. There's some newer medicines that we use, gabapentin, Xanaflex. This is a very much studied aspect of total knee replacement, pain management. And so the full recovery, you can walk on it right away. We encourage people to bend their knee right away. It's interesting. I was at a meeting over the weekend, a total joint meeting in Orlando. And the newest thing is to kind of step back from therapy and let people go at their own pace, because sometimes I love our therapists and they're trying to meet goals, but for some individuals, it's too aggressive. And so sometimes if you step back, and there's even data now suggesting that we don't need any therapy for total hip patients.
Wow. Interesting. Oh, that's great. And it'll be interesting to see how that plays out in the future.
Right.
Super.
So I would say the overall recovery, just the last comment on that, on average for a total knee replacement is 4 to 6 months. If one has a partial knee replacement, it's probably 2 to 3 months.
Great, thank you. And in a typical month for you, what is the percent of total knee versus partial knee replacements that you do?
Oh, it's a lot more total knees because there just aren't as many candidates who fit the criteria to undergo a partial knee. It's maybe 80-20, 90-10 if you consider the 20 being both patellofemoral. I mean, we only do a few of those a year because there just aren't as many patients who are candidates, but the partial knee on the inner side is more common.
Got it. Great. Okay. All right. And it is 8 o'clock. So I always try to, we start on time, and I want to be respectful of your time, Dr. Summerville, so we will end on time. For those of you whose questions did not get answered, you can reach out to Dr. Summerville on the screen that's showing right now. And also for those of you who asked for copies of the slides, remember this whole program will be posted on both the IBJI and the NSYMCA websites. And if you go to Dr. Summerville's page on IBJI, you will find this program there. Give us a couple days to get it up, but it'll be there within the next week or two.
Okay.
Dr. Summerville, thank you so much for your time.
Thank you, everyone.
Great to meet you.
Thank you, Karen.
Thanks, everybody. Have a great night.
Bye.
Bye-bye.